Uh, Half an hour ago, to make a keynote speech, I was not ready. So, for the last half an hour, I just tried to collect these for you. Bill Gates says that the first rule of any technology is that automation applied to an efficient operation will magnify the efficiency. But in contrast, the second rule is that automation applied to an inefficient operation will magnify the inefficiency. Is robotic cardiac surgery a complex task? Yes, it is. So, we have to take all the precautions before and after during and after the procedure. Human error is in our nature and it might happen in any context. And rate of adverse events related with human factor is somewhat about 3%. But when it's an interaction between human and machine, then 80% of the cases error is belonging to human, and 20% of the cases to the machine. What are the human errors? First of all, the complexity of the task is the main factor that increases the rate of human error and decreases safety. So, as we said before, robotic cardiac surgery, actually cardiac surgery is a complex task. So, simplification increases safety and decreases the rate of error. Other causal factors of human error are inadequate risk assessment and supervision, inadequate work standards, procedure and infrastructure, improper decision making, and inadequate training and competence. These all we can handle actually. It's not our fate. Management of human errors before the event is first simplification. So keep what you're doing as simple as possible. And the second one, most important second one, is standardization. Plan your procedure and try to do always the same way. Not change your habits in every case. Not change your standards frequently. And also this brings decreasing the variability. And risk modification, safety control, as I want to stress during daytime. For example, in our practice, transesophageal, please do not do that. And after the event occurred, the crucial steps are rapid detection of the error by, of course, monitoring. And for that reason, you have to monitor everything. The cerebral oxygenation, pulse oxygenators, peroperator, transesophageal echocardiography, because they will alarm you before the event and understand what's going on and correct it properly. Why we are very eager to do minimally invasive and robotic surgery? Because it's proven that it's associated with shorter hospital length of stay, less trauma, less bleeding, less transfusion. Actually, transfusion is a major issue for me during all my surgical career. In Turkey, we have a motto, blood saves lives. But on the other hand, blood kills people if it's not appropriate for many reasons. Less pain, lower infection rate, avoidance of sternal complications. This is an issue. Sternotomy itself is a major procedure. Imagine you just open the sternum and close it. You didn't even touch the pericardium. This is also a big operation. And another issue for the patients is faster recovery and return to work, and maybe the last thing is cosmetic. Is there any disadvantage of minimally invasive surgery? Of course. First of all, lack of tactile feedback, especially during robotic operations, is an issue, but visual feedback replaces this tactile feedback after a couple of cases. And the recent Da Vinci 5 system has also a tactile feedback capacity, but the instruments are expensive, so I don't know if it will be really change the situation. Just accept longer operation times, especially in the beginning of the practice, and convince the team that this may take longer compared to open cases. And of course, the cost is the most controversial factor, because if you decrease the rate of transfusion, if you decrease the hospital stay, if you decrease the ICU stay, this will probably cause the procedure to be less costly. Here is my first proctor. Actually, I went near by him after I started robotic surgery. 1 year after I started robotic surgery, I started in 2009, and this photo is dated back to 2010. As you all know, Dr. Randolph Chitwood, and the lady on the left side is my chief scrub nurse, Leyla, founder of Leyla, and I've been working with her for the last 33 years. And this photo dates back to 2014. It was during the first robotic meeting held in Turkey like this one. And the attendance was over 400 people. It was amazing. And the guy here is Randolph Chitwood, Wiley Nifong. He was the console surgeon, bedside surgeon of Randolph Chitwood, and he was with us during that meeting. And after the next year, in 2015, we held the ISMIX winter workshop in Istanbul with an attendance of more than 600 attendees. Personally, I have done my first OPCAP procedure in 1990. I was a young resident there, and first minimally invasive cardiac surgery in 1992. Now, maybe most of you don't know that incision, but it was a parasternal incision. I don't know why, but it was at that time like this. And I did a AVR. And also, what I believe is the cardiac surgeon must get the catheter in their hands, guide wires and catheters in their hands. I am lucky because I am cardiovascular surgeon and I am familiar with endovascular procedures. And these two cases are the first in the world literature, both of them. One of them is endovascular stent graft treatment of type A dissection, dated back 2007, and another one is hybrid treatment of ascending aortic pseudoaneurysm with extra endovascular stent graft and extra anatomic reconstruction without sternotomy. But at the same time, we were doing these operations as well. Clenchal incision, maybe most of you didn't see before, or I believe didn't perform. But we were doing arch aneurysm surgeries like this, or you have to do it in two steps. First, the arcus and ascending and arcus aorta, then put an elephant trunk graft. Then in the second operation, make a big thoracotomy and find the graft inside the aorta and suture a second graft to it. Nowadays, we can do this operation with a mini sternotomy with frozen elephant trunk technique. So the times are changing. In 1999, I resigned from government hospital and started at Acıbadem Health Group. And after that, I have my own database, and so far, at the end of 2023, I personally performed over 10,000 operations. And interestingly, after I started robotic surgery, so far I have done 614 cases myself, and with my team over 1,000. And I practiced over 500 cases worldwide, including Turkey. But if you look at the numbers, sternotomy at the beginning was major procedure. It was 76%, and 18% of the cases were robotic. But for the last 2 years, when we looked at our database, for the first time in our practice, robotic procedures exceeded sternotomies. It was 44.5%. Both, and including minimally invasive surgery 11%, 56% of the cases were done in a minimally invasive manner. And today you asked what were the percentages of robotic procedures. This is my personal data. 64% is mitral and tricuspid, 25% CABG, a few AVRs on the last years, and rest is myxoma and ASD closure. For the last 2 years, we started, after I visited Alexander Babiak, I started the technique that I showed you today. And for the last 2 years, we are doing Aristotard robot-assisted mini CABG with full revascularization, and stroke rate and mortality, thanks God, is 0%. And these are the first done by our team in Turkey and in world. These days were like this. If you do anything extraordinary, probably it was the first time in your country or in world. So I feel that I was lucky. What I advise for young surgeons is for the first mitral cases, learning period for lima takedown is quite short. It's 5 to 10 cases, probably enough. But for robotic mitral cases, to achieve a safe learning period, please start with P2 prolapse, which is the simplest case. And after 20-30 cases, you may step up to myxomatous cases and anterior or bileaflet prolapses. This is my learning curve from the very beginning. So after 25 to 30 cases, it reaches a plateau for cardiopulmonary bypass and for cross-clamp times, and there is no difference between replacement and repair. We also introduced fibrillatory arrest technique without cross clamp, as I showed some cases, some samples today. So far, until the end of 2023, we have done 37 cases. The mortality rate is 5.4. It seems a little bit high, but these patients are really very sick, cannot be operated by any means. Euroscore, mean Euroscore is over 15% in these patients. So I hope you can imagine the situation. And lastly, I try to share my experience with my colleagues. So for that reason, we have published many publications, and this is my personal robotic publications. So far 31 publications, including some new techniques. And also I take role in training many teams in Turkey and internationally. I visited some centers more than once for coronary and for mitral intracardiac. And as a conclusion, I believe that in experienced centers, robotic mitral valve surgery may be suitable for almost all pathologies, including complex pathologies like valve loss, annular calcifications, reoperations, and all kinds of concomitant procedures. Thank you very much.